Hi, everyone, and welcome back to Critical Care Ultrasound. And let's talk about the heart, okay? So we're going to talk about some basic cardiac views. We're going to interpret the most important part of the heart, which is the LV. How is it functioning? So when we talk about some basic cardiac views and interpretation of LV function, that we really need to go back to the basics, which is going to be, why are we doing this to begin with? And the answer is going to be, well, for hemodynamic monitoring initially. There are so many other things, but remember, we're doing this for critical care right now. And in critical care, we love one thing, which is what? Shock. Why are you in shock? What type of shock it's going to be? And this is one of those things you could do at the bedside to, with the other pieces of information, figure out why the patient's in shock. Now, how do I start this lecture and why are we using the ultrasound? Well, if I were to ask you the question, is shock defined by having low blood pressure? Well, the answer is kind of not really. Don't get me wrong. I mean, all shocks pretty much have a low MAP, but shock is all about impaired tissue perfusion. Problems with oxygen delivery, problems with oxygen consumption. And a huge part when we talk about oxygen delivery is going to be what? The heart. And when I say the heart in general, what function am I talking about? The cardiac output, And let me just take it up a notch. I asked you about hemodynamic monitoring and low blood pressure. I mean, don't get me wrong. The MAP, mean arterial pressure, is probably going to be low in any type of shock. But MAP, if I asked you, what is the equation for MAP, it really is that cardiac output multiplied by total peripheral resistance. So why am I even mentioning this to you is that when we want to kind of categorize the different types of shock, well, it doesn't matter. We know the MAP is going to be low, but there are certain shocks that have a low cardiac output, such as hypovolemic shock, cardiogenic shock, and maybe even something called obstructive shock. And so if your cardiac output is down, your MAP has to be down. And we said the formula is going to be MAP is equal to cardiac output times the TPR. And there's only one type of shock that's going to give you a very low total peripheral resistance. That's going to be what? Distributive shock, something like sepsis. So, this is going to be a nice way, just having low blood pressure to MAP and using its formula to categorize the different types of shock. And why is this important is because by using the ultrasound, by looking at the heart, by looking at cardiac output, we could say, hey, most likely this patient has a low cardiac output type shock, or we could say that maybe the heart's not doing as bad. This could be a problem with maybe some kind of distributive shock. So that's one of the biggest things about why do we use this. And when we talk about hemodynamic monitoring, of course, there's always going to be a role for invasive, doing an arterial line. And of course, that's how sometimes we measure the MAP itself, or sometimes we do it because we do need to get arterial blood gas because they're going to be on the vent for some time. Central lines, maybe we don't use it as much anymore to getting a static measurement like the central venous pressure, but sometimes patients need access. Sometimes they need to be on pressors that can be given through a central line. Same thing when we talk about, a Swan-Ganz catheter. Of course, we use Swan-Ganz less and less, especially in the medical ICU, but it's because of the non-invasive things, really focusing on, a focused ultrasound, a bedside echo to help us tell us information about the heart and how does it contribute to figuring out my differential of why this patient's going to be in shock. So when we talk about ultrasound of the heart, we call it point of care echocardiography, and it's also known as basic echocardiography. It can be goal directed, it is limited, or it's called resuscitation echocardiography. And when we talk about it for resuscitation, there are different protocols in what we do to figure out why is the patient going to be in shock. So if I am going to use that ultrasound, you've got to have a purpose. You've got to have a game plan of what you're going to do when you evaluate the patient. And a lot of the things we do to patients are based on existing protocols. So we'll talk about the fast or the extended fast. We'll talk about the rush protocol, the falls protocol, and there's something else called the blue protocol. And these are just going to be some studies and research to show us what would be a way to quickly evaluate the patient and figure out why they're short of breath or why they're going to be in shock. So when we talk about the FAST protocol, it's going to probably be around, the longest, and many of you have heard about this. They do it quite often in the emergency department. Trauma does it quite often. And when we talk about FAST, it stands for Focused Assessment with Sonography for Trauma. So when we talk about the FAST, I think back, and I remember that the FAST was duking it out with something called a diagnostic peritoneal lavage. Not to say I ever did one, but that's when someone comes in with trauma, and that's why we use this in trauma, and you thought they were bleeding from the internal organs in the abdomen. How do you know? And I remember when you used to watch these TV shows like ER, they would do that diagnostic peritoneal lavage where they'll make an incision, put in the catheter, throw some water or saline in there, and they'll suck it back and see if there's blood in there. And if there is, they may need to go to the OR. But of course, doing a diagnostic peritoneal lavage has become second because of, people are so good with using the ultrasound and of course other types of imaging. So doing a FAST, look at the classic places that you see on this diagram, to see if there's going to be any blood in the abdominal cavities can be very, very important. There's something called the EFAST, extended fast, where the E means that you're going to be looking for a pneumothorax. And it makes sense. Someone comes in with trauma, they're very short of breath, they're hypotensive. It could be a tension pneumothorax, maybe it's a penetrating injury to the chest. And the EFAST helps you look for the detection of a pneumothorax. So what are some of the protocols that we use when using the ultrasound in the ICU? One of them is called the rapid ultrasound for shock and hypotension. We call that the RUSH protocol. And the RUSH protocol basically divides, what you want to do with the ultrasound as looking at the pump, looking at the tank, and the pipes. So of course the pump refers to the heart. How is the left ventricle doing? How is the right ventricle doing? How is the left ventricle working? Is it contracting? Is it squeezing? Is there a pericardial effusion? Thinking about some kind of obstructive shock. The tank is going to be the venous circulation. Remember, almost 70% of our total blood volume is in the venous circulation at any one given amount of time. So you can look at the IVC and look at other places where fluid can accumulate, like the pleural space, like pleural effusions. And you want to look at the pipes, and of course, referring to the aorta. You want to know if there's aortic dissection. You want to know if, on the venous side, in the venous circulation, is there a DVT there? And we'll talk about, how do we evaluate individuals for deep vein thrombosis, really focusing on the legs. The FALLS protocol is really looking for etiology of shock. So when we talk about the FALLS protocol, we'll kind of walk through this. Someone comes in and they have a low MAP, mean arterial pressure, low blood pressure. What is the possible causes? So when you do the ultrasound, you look for things like, is there a pericardial tamponade? Is there a tension pneumothorax? And of course, these are going to be examples of obstructive shock. And if you do see it in the right setting, should you do a pericardiocentesis? Should you do a chest tube, to address those appropriately? Or in the right setting, maybe you see a lot of, B lines, like they're fluid overloaded. Maybe they're in the right setting, they're in cardiogenic shock. Maybe you're looking at the squeeze, you're looking at the pump, and it looks like the left ventricle isn't working. Maybe when someone has, low blood pressure and you give them fluid, maybe it's going to be hypovolemic shock. But maybe if they're not improving, in the right setting, you start seeing more and more B lines, and we'll talk about B lines and A lines and all these things in a bit. Maybe there's septic shock, So this was, an overall concept, a protocol on why do we use point of care ultrasound focusing on the heart. So I did mention there is a BLUE protocol, and BLUE stands for bedside lung ultrasound in the emergency setting. And when we do the BLUE protocol, there were these zones, zone 1, 2, and 3. Sometimes we call it Blue point 1, Blue point 2, and zone 3 is called the PLAPS point. And PLAPS stands for posterior lateral alveolar pleural syndrome. So basically zone 3 is going to be, looking for pleural fluid. Because where is pleural fluid going to accumulate? It's going to be more dependent towards the back. So of course, we talk about these PLAP points. So when we talk about the BLUE protocol itself, there is a certain way of how we could look at different aspects with the ultrasound to determine what is the most likely etiology. So this is going to be the protocol, and we're going to use things like A lines and B lines that we haven't talked about yet, that we will coming up. We're going to utilize lung sliding, which we'll talk about more when we talk about pneumothorax, to figure out, why is the patient short of breath? So, in this case, we're going to start off with lung sliding, and this is going to be something that we're going to use to determine if there's a pneumothorax or not. If lung sliding is absent, likely going to be a pneumothorax, but we're also still going to look at B lines and A lines. If there's B lines, we'll go into more detail, but it's probably not going to be a pneumothorax. If there's A lines, we see A lines in a pneumothorax, quite commonly. So what are we really looking for is something called lung point, which is going to be what we consider the gold standard to really call it a pneumothorax. If you don't see lung point, we use the word probable. Now, if there is B lines over here, then we could think more, especially if it's going to be unilateral, we could think of a consolidation like a pneumonia as being the cause of the patient's shortness of breath. Now, if lung sliding is present, we know there's not going to be a pneumothorax, then we will use a lot of these artifacts. If there's a lot of B lines, especially if it's bilateral, maybe they're fluid overloaded. If we see A lines, and once again, A lines can be seen with a pneumothorax and without a pneumothorax, that, hey, we still don't know exactly what's going on. Maybe we'll look for, a clot in the lower extremities, because if someone has a DVT in the acute setting, it's probably, it's not unreasonable to think they have a pulmonary embolism. And of course, the treatment for both a DVT and a PE in the initial setting, in the acute setting, is pretty much the same. You're going to anticoagulate them. And of course, if they're hypotensive, you could definitely think about doing a revascularization, whether it be through thrombolytic, or if you could confirm there's a PE, obviously in the lung, other ways to do it through minimally invasive procedures. And then if you still don't see a DVT and the patient is still short of breath, you could go to that PLAPS point, which we're talking about over here, which is going to be that zone 3, and really look for things like a pneumonia, a pleural effusion, consolidation, to figure out what's going on. So all these protocols we just talked about, the RUSH protocol, the FALLS protocol, the BLUE protocol, are different ways when you're evaluating someone for shock in the medical ICU to have a certain a pathway to go by, a protocol to go by, to think about what are the causes of this patient's clinical situation. So, all of these different protocols I've been talking about have one thing in common, that they use a limited number of echo views. They're for rapid evaluation of hemodynamic failure, and they're to identify life-threatening processes, talking about the tension pneumothorax, talking about the pericardial tamponade. They help categorize why the patient's going to be in shock, and hopefully they're going to help you guide management of this patient. Maybe too much fluids, maybe a little bit more fluids, and also you could use it to follow the evolution of disease in response to therapy. But by no means does, doing basic, echo going to replace getting a full echo exam done by a cardiologist or someone who is certified in, doing echocardiography.